one slide, there are two kinds of cells in the heart, autorhythmic and contractile. The contractile cells are the muscle part of the heart. They're basically most of the heart. The autorhythmic cells are less than 1%. They're a very small percentage of the heart, but they have the most important job of having this pacemaker potential. They're less than 1% of the heart. They're an intrinsic conduction system. With each heartbeat, the signal spreads over the whole heart. So any group of autorhythmic cells that can self-generate action potentials, they call that the pacemaker potential. So autorhythmic cells have pacemaker potential. Let's spread the depolarization throughout. The whole heart. With each cardiac cycle. I know pacemaker potential sounds like a weird term. Shouldn't. You study the action potential. This is a different kind. Okay. This potential allows, well, I'll go through it, but this pacemaker potential is very important. It determines heart rate. Okay. Make that connection. Pacemaker potential determines heart rate. So before I leave this slide, I want to go through all the different kinds of cells, how the signal spreads, and which cells have this pacemaker potential. Just use my simple illustration of the heart with our 4 chambers. You want to start paying attention to the most important part of the heart that starts the heartbeat. That's this right here. It's called the SA node. I'll draw it as a little. I'll use red. Look for it inside the right atrium of our heart models. Call it number 1. The SA node. The full name is sinoatrial node. I just call it SA node. I'll describe it as the number 1 pacemaker. It's the strongest, and the strongest pacemaker commands the heart rate. It controls everything. And if everything's going well with it, they call it your sinus rhythm. It establishes, let me put it this way, what's called normal sinus rhythm. Now, if you kind of looked at the cells within this node, they could self-generate action potentials at a rate of 100 per minute. So the autorhythmic cells in this SA node AP is action potential. AP is action potential. I use that abbreviation a lot. So that's basically your heart rate. Now, average heart rate is a little less than that. It's about 75 beats per minute. So there's some parasympathetic activity that kind of dampens the SA node. But the signal starts there, and it spreads first through the atria, through internodal pathways. Okay, so I don't know, call it internodal pathways, spreading through both atria. So the signal spreads, let's just say spread through atria, the right and the left. So the cells, there's no pacemaker potential within any cells in these pathways. You're just basically trying to get the signal to the next node throughout the atria, through right here. The next one is the AV node. I'll put it right here. Also look for it in the right atrium, right here. I'm on number 3. Atrioventricular node, or we just call it AV node. Those cells have pacemaker potential, so I guess it's the second strongest, number 2 pacemaker. As long as the SA node is active, you never let the AV node be the rhythm setter. Okay. It could, but the rule is the strongest one always commands the heart rate unless something's wrong with it. So this is your number 2 pacemaker cells. And this node can generate about 40 to 60 APs per minute. So it's basically a lot of pathways converging on this single node. And to get the signal to spread from the atria down to the ventricles, which is crucial now. Okay, so notice that in a cardiac cycle, we stimulate the atria to contract first. Okay, because when you stimulate the muscle, it will contract, just like skeletal muscle. But the atria contracting aren't as important, right? We talked about how atrial systole contributes to ventricular filling, but it's the ventricles contracting that's key for cardiac output. Right now, the signal is stuck at one little point, number 3, and we're trying to get it down to the ventricles. The way it spreads is not just, it doesn't spread just all the way down like this. It first goes down one point here, down the middle, down the interventricular septum. There's a little bundle right here after the AV node. Called number 4. It's called the AV bundle or bundle of His. Because it's a single bundle, and it's trying to receive all these signals from above, we notice a conduction delay at the AV node. So the bundle of His causes a conduction delay at the AV node because of this like bottleneck effect. Causes a conduction delay. At the AV node, has a quote-unquote bottleneck effect. The signal slows down. Basically, the conduction delay is 0.1 seconds. Yeah, just to put a number to it. Remember how long a cardiac cycle is? 0.8. This is like 0.1 and 0.8. A little delay as the signal tries to push down the septum. So this is interesting. We're stimulating the ventricles, but not yet, because you're contracting the septum in between them. If you want to pump blood out of the ventricles, you can't just stimulate the septum in between, right? That's not going to do anything, and that's good. Because what it'll do is, it'll spread the signal to the apex of the heart, and then the signal will be forced to go up the sides of the wall. And then that's where you kind of squeeze the heart. The heart pumping is squeezing. That's essentially what you're doing. Like you squeeze a tube of toothpaste, you squeeze the heart to wring blood out of the ventricles. That's how it works. So this is good. We just kind of like go down the septum first, then up the sides. So you squeeze from bottom up, right? Because if the signal spread all the way down, I mean, it's like, you can't, it's hard to squeeze that way. It's better to squeeze from the bottom of the heart up. Now, what's going to happen is this single bundle of His will divide into two bundle branches, a left and a right. Okay, so I'll call it number 5. Left and right bundle branches. They're branching off the bundle of His. And before I erase it, I just want to emphasize how the delay is a good thing. You know, when I showed you that animation of the heart beating, the two atria contract, then the two ventricles. So there's a pause between the atria contracting and the ventricles contracting. You want the atria to contract first to finish filling. Then you want the ventricles to contract. And the reason why that happens is of the delay. You delay the ventricles from contracting too soon. So the delay is really a good thing. That allows a full time for the filling to finish before the signal can spread down to the ventricles. So number 5 is left and right bundle branches. Signal spreads down the septum to the apex of the heart. Now, what you do is, there's these fibers called Purkinje Fibers, I mentioned them before. Allows the signal to spread up the sides of the ventricular walls. And as it does so, it gives like these little branches that go inside, say for example, papillary muscles. That occurs in both ventricles. Kind of go up the sides, you give up these little branches. Called Purkinje Fibers, and they also stimulate papillary muscles. But basically call them all these things going up the side. I'll just label it number 6. They're the Purkinje Fibers. Purkinje fibers are modified muscle fibers. They conduct the signal up the sides of the heart. Also, they conduct depolarization up the sides of the ventricular walls. They have pacemaker potential. They're your number 3 pacemaker. Cells could generate APs, something like 20 to 40, not very much. So they make the whole ventricle contract. I emphasize the papillary muscle because it's like the papillary muscle will contract a little bit before the rest of the ventricle does, and that will help keep those AV valves closed during the systole. So it's important that they contract first, because you remember what the papillaries are attached to? The heartstrings. Those are attached to the valves. So it makes them more effective in keeping the valves closed so you don't get that regurgitation of blood flow during systole. All right, so, but that's it. So I just described how the signal spreads through the whole heart. It helps generate one heartbeat. Okay. So that's kind of that picture there. Signal spreading, SA node, AV node, bundle of His, the bundle branches, run the septum. You go to the apex of the heart, then you spread up the sides, and then you can show like I did, like the Purkinje fibers going in the papillary muscles. So when we do the ECG, we want to take a picture of this. The electrodes can do it. And the ECG is just like taking a picture of the heart. Okay, I mean, literally like you would take a picture of, say, a car. But depending on where you place the electrodes, it's kind of like it gives you a different view of the electrical activity of the heart. Just like this view would give you a front view, and those cameras in the back will give you a different view from the rear of the same car. Okay, the analogy is it's a pretty good one. So just think of your electrode when you do this lab on Wednesday as the camera. And depending where you put the lead, it'll give you a different perspective of the electrical activity of the heart. And traditionally, students who do this, or nurses who do this, or doctors who do this, technicians who do this, it's a 12 lead. Give you 12 views of the heart. So there's a boy with a 12 lead, and we're not doing a 12 lead. We're just doing 1 lead. But here's the 12 views of the heart you might see in a typical readout. For our lab on Wednesday, we're just doing lead 2. This is kind of the prototypical one. Okay. Lead 2. You got 12 leads, we're just doing the one called lead 2. And some people may have experience doing this. You always have to do lead 2. I remember I had a paramedic student, he just tried to do something else. So he was used to doing it in the field. It didn't work. We're set up for lead 2, so you have to follow our procedures. The 12 lead ECG produces 12 views of the heart. 12 views of the heart's, I should say, electrical activity, that depolarization spreading. we're just doing lead 2. All right, so to give you a bit of a background of what the leads do, you can put like an electrode on the limb, and it's weird. It can monitor the electrical activity in the heart. I know you don't really think that. You think you've got to put it right on top of the heart. You do for some leads, but the limb leads work really nicely. So on this picture here, what we see are the limb leads. You can like put a lead on either wrist. That's lead 1. And what a lead is, well, you need 2 electrodes, like a negative and a positive, okay? And so like a negative positive pair of electrodes is a lead, okay? So what you see here is like 2 electrodes here give you this lead, or put one here. Here's lead 2 on the right one, and another one here on the ankle. That's a lead. That's the one we're doing. Or on the other extremity, you give you that. That kind of makes a triangle, right? Or the ones here. And you're basically in the frontal plane when you put the leads in any of those positions. If you put them across the chest here, okay, technicians learn how to do this, you're basically getting a transverse view of the electrical signal spreading through the heart. Okay, so we're doing just this one in the frontal plane. Here's from the Marionette procedures. You got negative to positive, white to red, and the black is a third electrode. It's just a ground. Okay, so negative to positive should produce a result that looks something like this, a lead. Now what you're doing is, it's this axis. Lead 2 is, that's the approximate axis, negative to positive. So when the depolarization spreads, I mean, this isn't the anatomical position of the heart and the chest, right? But just to give you an idea, we're watching the signal spread from that particular lead. Lead 2, when the wave of depolarization moves toward the positive lead, there is a positive deflection in the ECG recording. So if you have a flat line, well, if everything is flat, you get nothing, right? I mean, the heart's not beating. But they call the baseline an isoelectric line. Think of that as your baseline, isoelectric. Let me spell that right. 2 words. It's kind of like your baseline, your 0 point. If you see a deflection from the isoelectric line, that simply means that the polarization. Well, actually, let me define this. If you're flatlined, if you're at isoelectric line, what that could mean is the depolarization is traveling perpendicular to your lead. So it just registers as flat, you don't see it. So the depolarization is traveling perpendicular to the lead. Doesn't mean anything's happening. It's not the absence of activity. It's just the depolarization is traveling perpendicular to your lead. Ours is lead 2. So if you see a deflection, that means the depolarization is traveling toward your positive lead. Any deflection. Any deflection means the depolarization, the dipole, is traveling toward your positive lead. You're putting yours on the ankle there, the left ankle. And again, this is Wednesday's lab. So, because I want to give you time to like study the Ecg components before you come in on Wednesday. You're gonna have to like measure these. So let's go through the Ecg components for lead 2. So the goal now is for me to show you a typical Ecg. I remember one year the student was taking a test, and I guess I was bored. I just did my own Ecg sitting up here, and it wasn't very good. And you know what? I said to myself, that's good to present. Don't give them the textbook ideal, because they're not going to see it when they do it. So get them to like look at something that's a little imperfect, and let their eye be trained to kind of look at the imperfect, because when you do lab, when you do this in the clinics, you never see a textbook one. Sometimes you do. Sometimes I walk around and say, wow, yours looks really good. There's variables. Like for example, when you put it on the skin, I mean, it's like, I'll give you a little abrasion pad to scuff away some of the dead skin cells. I'll give you a little alcohol wipe to get some of the grime off of there for a clearer signal. I'll give you a little bit of gel, because these things sit in the shelf and the electrodes dry out. So I'll give you everything to get the most optimal lead. But even then, it might be a little noisy. And so the goal for me is to show you how that represents the cardiac cycle. Because you have to know exactly what you're looking at, so you know what's going on in the heart. You know, if you're a cardiologist, you can like help your patient when there's a problem. All right, so let's start with the first deflection. It's called the P wave, and it represents the atrial depolarization. And let's remember that anytime you have a depolarization, immediately following is a physical contraction or systole of that area of the heart. All right, so P wave. And so I've highlighted it here in blue. I did that on the computer screen, just did a screenshot. And here I give you the textbook average, and that's good to you know, take note of as you're doing the lab. Students, you always doubt yourself, right? Because you're a student, you're learning, you're like, oh, am I doing this right? Well, if you're within the textbook average, you are. Then you can always get me and I can confirm for you. So the P wave, that first one there, well, it represents, well, let me first do this. Let me just kind of, let me draw the whole thing. Isoelectric line, P wave. Well, let me on the board draw what a textbook usually shows you compared to my ECG right there. I mean, that's literally my ECG, okay? And if you're the subject of your lab, yeah, you get to see your ECG. And while I'm thinking about lab, there's a part of the lab that has the subject lie on the floor. So if you can get together in a group today and say, hey, does anyone have like a yoga mat or something, exercise mat? So when you lie on the floor, you're a little more comfortable. Okay, just keep that in mind for Wednesday's lab. Okay, so that's basically it. So the P wave is, I'm going to draw it this way. I'll just draw the wave I'm talking about in red here. That's the P wave, that deflection. And the P wave represents atrial depolarization. So think about when that is. When the atria contract, you're somewhere in ventricular filling, kind of mid to late ventricular filling. So if you've been studying the cardiac cycle, and I hope that you are, even though I didn't quiz you today, study. Here's the P wave right there, right? And this is the thing I taught the last time. See how it kind of lines up with what we were talking about, kind of mid to late-ish diastole? So we're in ventricular filling. That's kind of what that means when you see it in the subject or a patient. So then the signal spreads, and you get down to that AV node. So the yellow on the illustration represents the polarization. So when you get to the AV node, there's a conduction delay there. I had said that previously. It's about, I said 0.1 seconds, which is about 100 milliseconds. The depolarization is delayed from getting down to the ventricles. So there's time between inflow and isovolumetric contraction. Good, and basically we want to measure this delay. And you can do that by measuring what's called either the PR segment or the PR interval. So what I have here is the PR interval. Let me just draw that. PR interval. So if you can do the PR interval, what you would measure is you would get all the P wave and that isoelectric line up to that downward deflection. So what I have there in red, and you highlight that amount of time, you're estimating the conduction delay is the PR interval. It's about 0.12 to 0.2 seconds in duration. That's one I'm noting there. It's clinically significant. If it's if the delay is too long, well, we don't like that. I mean, you could have some kind of heart block. Heart block is the signal's not getting down to the ventricles. It's blocked. So that one's kind of important there. So you can either measure the PR interval or the PR segment. I mean, technically, the delay is just the segment, not the whole interval. But let me draw what I mean by that. And that's the segment right there. So if you're just measuring the segment, it's just, you don't include the P wave, just the segment between the P wave and that downward deflection, that little blip right there. That is also a measure of conduction delay. Okay, both of these are. However, that segment is much shorter. It's going to be maybe 0.8. I mean, that should be 0.8. That's a mistake. It should be much shorter because you're not including the P wave. But both measure the delay because the big spike is the ventricular depolarization. So by measuring the time before the big spike, you're measuring the delay of the signal getting down to the ventricles. Okay? That's how you think of it. So the delay is 0.1 seconds, but when you measure these segments or intervals, and we have the average times for you there. So I put a box around the PR segment for the Wigger's diagram, and you can see the box is, where the PR segment is, it's literally right before the first part of systole. Okay, so the ventricles have not begun to contract yet. So this is at the very end of, it's at the end of inflow. Think of it that way. So this segment or this interval is a measure of the conduction delay in the cardiac cycle at the end of inflow, at the end of diastole. So when you measure the PR interval and it's too long, it could indicate a heart block. So what I have here is some textbook ECGs. The top one is normal. Then first, second, and third means what's considered first degree, second degree, or third degree heart block. Now, first degree heart block, and we're going to have in the slide, if the PR interval is just too long, greater than 0.2 seconds. That's first degree. Greater than 0.2 seconds, just the definition of a first degree block. The signal's still getting down, it's just taking a little longer than you would like. Now the second degree, they call it a partial or intermittent block. The PR interval kind of gradually lengthens, and then the AV node fails. So if you look at the second one, you have a PR interval, it gets longer and longer, then basically you skip a heartbeat. There's no R wave. Okay, R is the top of the spike. So if there's no R wave, you skip a heartbeat. That's a partial or intermittent block. Longer PR intervals, followed by no R wave. You skip a heartbeat. So when you skip a heartbeat, the signal didn't get through. The AV node failed. The third degree is a complete block, for whatever reason. We call it complete block or AV dissociation. The signal's not getting down to the ventricles at all. So the only thing contracting the ventricles are the Purkinje fibers, which aren't that reliable. But what the ECG would show, random P's, random Q's. There's no relationship to them. I'm sorry, random P's, random P waves, random R waves, random P's, random R's. P wave I mentioned, these little spikes are the R waves, and there's no relationship to the P to the R because they're just kind of operating independent of one another. So, be able to identify first, second, third ECG. Let's pretend that the signal gets through and goes down the septum to the apex. So on this figure here, we have two different colors. The red symbolizes repolarization, yellow is still depolarization. So the signal has now spread from atria and is going down to the ventricles. So during this time, the atria are in repolarization. So the bundle of His go down the bundle of branches and you get the Q, it makes the Q wave when the signal spreads to the apex. Just that part is the Q wave. It's hard to see. Sometimes you may not see it at all. And you see that it represents the polarization having spread to the apex of the heart. Depol spread to apex of heart. This picture reminds me to teach you something here. Okay, so I got a couple of pictures here. The picture on the top showing how the signal spreads only down the septum. And there, I said earlier, why doesn't the depolarization just spread down in both cases? It can't, it's blocked. If you look at all the heart valves here, what I didn't mention is the valves are supported by a fibrous ring structure. If you remove that structure, this is it. This supports the valves. It's kind of like fibrous skeleton for the valves. They're made out of connective tissue, and connective tissue doesn't spread signal well. So that's why the signal just doesn't spread from up here to down there. It gets bottlenecked through that one little bundle of hiss. So on here, I always like to ask students, can you find the opening for the bundle of hiss? And it's right here, that tiny hole. That's why there's a delay. You're forcing the entire signal through that one little hole. It can't go down anywhere else. Okay? So remember what that tiny hole is. Be able to identify that. I always like to ask you that on stuff. And, if you weren't remembering to study it, you'll have no idea what that tiny hole is. I was supposed to do that. It's so important. Be able to ID. The opening of the bundle of hits. Put that there so you're not fooled by later. Opening for the bundle of hits. Let's move on. Well, now the signal can spread up the ventricular walls, and this is the main event. This is the depolarization that will cause the ventricles to contract. It's called the Qrs complex. It's the whole big spike. So Q, R, S. So if you're doing the letters here, P is the P wave, Q, R, S. Kind of do it like that. But what I have in red there is considered the QRS complex. Represents ventricular depolarization. I'll just write dipole for short. There's mine there. It's very quick. It's a very sharp spike, meaning it's very fast. And this is the Purkinje Fibers kicking in here. Remember I said that it's your number 3 pacemaker. They can generate 20 to 40 action potentials per minute. I guess you'd use them in a 3rd degree heart block when the signal's not getting through from the atria down to the ventricles. Okay. So remember, this causes systole. So they got the QRS complex on our graph right at the brink of systole. Or, we call it ventricular contraction, isovolumetric ventricular contraction, right here. So it precedes that, okay? So when you make the ventricles contract, what comes after that big spike is a segment that should be on the isoelectric line. Okay. Again, that doesn't mean nothing's happening. It just means the signal is like perpendicular to your lead. Which makes sense, right? That's how the heart sits on the chest. Oh, no, I got it. Let me tell you what this is. This is the ST segment. It's basically the flat segment after QRS, right there. This represents, during the cardiac cycle, peak systole, when the heart's pumping. So that's super important. So it's funny, the segment where it's like there's no deflection is the most important part, because it's when the cardiac muscle is in full systole, pumping the blood. So they kind of exaggerated here, but I put a box around ST segment, and you can see that it's occurring during outflow, right? You have the peak systole. There's peak systole here. They're ejecting most of the blood out during that flat part of the line. So it's very important. Clinically, if you're having some kind of coronary event, you'll see problems with this ST segment. ST depression below the line, it indicates myocardial ischemia. So depression may mean ischemia, which is a lack of blood flow. Okay. Depression equals ischemia. There's different kinds. Basically, depression below the line, ischemia. Now, if you have ST segment elevation above the line, it may indicate injury, heart attack, as in an acute MI. ST segment elevation equal acute MI. MI stands for myocardial infarction. I didn't use that term yet. Let me write it out. Myocardial a tech gave this to me. He was in this class, and he was like, oh, hey, I got this one. I always like it when the person who did it gave it to me. It's like first-hand information. I know I can Google this, but it's better when the source is like, you know, it came from the field. Well, anyways, what are you looking for? Which lead are we doing? Two, it's right here. So I kind of zoomed in on it. I'm pointing to it. So kind of see that, how it's like definitely above the line. It's like right into the T wave. You can't tell where one ends and one begins. So it was unconfirmed, but that's an example of it. All right, well, so the ST segment just represents the peak systole. If you want to like know the entire systole, what you could measure is the QT interval. Shown here. You get all of it. That's like all of systole basically. So the QT interval, well, let me stick to drawing it first, like I did. We'll call it. So what you would measure is, you'll start at the Q, get all QRST, and then just go, get all the T wave as well, get all that. So that represents QT interval. And what it represents is basically all systole. All of it. The full-on contraction, the full-on peak, and the full-on relaxation. So I just kind of boxed it there, and that's kind of what you're getting, all of systole. And one parameter that you'll measure in lab, as far as to vary QT interval, is after the condition of exercise. So you'll have one subject per group before your lab on Wednesday. Someone's got to lie down, but also someone has to exercise. So you might want to kind of discuss that within your groups today. So who's going to exercise? You got to bring your shoes, your comfortable clothing. And you can read the protocol. It kind of tells you what to do. It gives you some suggestions. And it's up to the subject who's physically able to exercise. Now when you exercise, I know we have different perceptions of what exercise is. I'll give you the physiologist view. You're inducing hypoxia in your muscles. Okay, that's how I view it. And what happens is your cardiovascular system tries to increase the output, right, to get the blood to the working muscles because they're hypoxic. They need more blood flow for the workout. So the heart has to be faster and stronger, right? So what would you expect to happen with this interval with an increased heart rate during exercise? It should be faster, right? So here's resting heart rate. Most young people will probably resting heart rate around 40, 50, 60. But when you get up to exercise, you should be getting in that training zone around here. Okay, you don't have to get to here. Here's good. Okay. You should expect to see a decrease in time for the interval. Okay. That's all you want to see. It's faster. The heart rate's elevated. QT interval is shortened a little bit. The other thing you'll measure is just the T wave itself. So that's the T wave right there. So just measure the T wave. The T wave represents ventricular repolarization. And this is kind of when the heart muscle starts to relax, like for example during isovolumetric relaxation. Here's a T wave there. So this is when after peak systole, then pressure starts to drop because the muscle's relaxing. That's kind of what's going on in the cardiac cycle.
Is that the love?
Yeah, happens during the second heart sound, well, which is not love, it's dup. Yeah, that's when the aortic valve closes, makes that second sound, which is the DUP, dup. That's kind of where you are in the cardiac cycle. And the other thing you can measure is what's called the TP segment, which is basically infinite, or most of it. So how you measure it is basically the time between two ECG cycles. So just measure that segment after the T and before the next P. It'll vary because it's based on heart rate. People's heart rate varies, so there's no set time. So basically that time between two cardiac cycles, call it TP interval. It represents most of inflow. So I kind of like boxed it there. You can kind of see it's like, yeah, most of inflow. Not all of it, but most of it. So it's a good approximation of what's going on there. Other things we have you measure, R to R. That's like heart rate. You choose R because it's like the sharpest spike, it's easy to see, and you just kind of like go from one to the next. And that time should be about 0.8 seconds, depending on what the heart rate is. It represents the heart rate, the time between the two. So I'll just kind of leave this up. But you just measure from this R to that R, call it R to R interval. Whatever it is, it represents heart rate, BPM. So if one, space between R to R is, think of it as one heartbeat. So if one heartbeat, let's say you measure the garden variety, 0.8 seconds. We'll got XS. Multiply that by how many seconds in a minute? 60. Okay, so do that math. Seconds cross out. I won't even do the numbers, but what are the units? Beats per minute, right? So anyway, 60 divided by 0.8 is 75. That's our garden variety. Yeah. What if you're younger and your heart rate is slower than that? What do you expect R to R to be? What's the relationship? Will this be longer or shorter? Longer, right? Maybe a full second. And then your heart rate's 60 beats per minute. Maybe longer than a second. With each heart rate. Some people have stronger hearts. Good for you. Yeah. Here's kind of all the normals and now the procedures that I have. Know that when I have you work in groups, I'm okay if you want to kind of just turn in one report for a group thing. And I understand that some students, you kind of like to turn in your own work. So I'm always fine if you like go solo or just turn in with the group. I'm fine with that. I always let students determine that themselves. I don't micromanage it. So just to kind of give you a preview for Wednesday's lab, we don't do the whole thing. We don't have time. Our labs are kind of brief here. We do have time just to do the biopack part. That starts on page 462. So these three segments there, you'll want to have the subject lie down, preferably on the exercise mat, just get a little bit comfortable as you can in this room. But that kind of like settles everything down. And the thing is, when they go from lying down to either sitting up or standing up, there's something that's called orthostatic hypotension. You know, you stand up after like sitting for a while, you get kind of lightheaded a little bit. What happens is all the blood vessels kind of dilate when you're lying down horizontal. Okay, and then when you kind of stand up, all the blood kind of pulls down a little bit. And you have these baroreceptors like here and here, right close to the heart. I should say here and here. And they kind of sense that blood is kind of going away, and blood pressure drops a little bit. And the reflex is to increase the heart rate to compensate. And so the reason why we're going from lying down to standing up is we want students to see that increase in heart rate. You'll measure a nice resting heart rate, subject's very relaxed here, and then they stand up, you should see a jump in heart rate to compensate for that drop in blood pressure. Of course, you'll detach them from the cables, you'll have to tell them to go out and exercise and come back, and the heart rate should be elevated from the exercise too. So that thing where you stand up and get lightheaded, of course there's a physiology term that's difficult to remember, and maybe not cut out there, I'll be right on the board. It's called orthostatic hypotension. You write that down. And this is actually something that's on lecture exam 4, not really 3, but 4. Okay. So this is, but you're doing it in lab Wednesday, so let me talk about it now. It's an observed drop in blood pressure after a subject stands up or sits up after lying down. So I'll say a drop in blood pressure observed when standing up or sitting up. I'll just say standing up after lying down. Lie down for a few minutes. So when you're doing this lab, be sure they're lying down. Maybe the rest of you guys are setting it up. You just let the subject, you just pamper them, let them lie down. You don't have to do anything. You're the subject, clean for a day kind of thing. Make your lab mates do all the work for you. Okay. The proper way to do this is not just to lie down and stand up. They put the subject on a table that tilts. So you literally don't have to do anything. And just tilting the table, you see the effect. But of course we don't have that, so you just have to lie down and stand up. That's good enough for us. Okay. Well, anyways, here's the data that you could record on Wednesday. We're not recording blood pressure. There is a drop lying down and standing up. But you see how you compensate? Look at the green thing above. On average, after standing up, there's a jump in heart rate. Okay, this is heart rate, this is BP. So you're trying to catch that after you stand up. Okay, but again, that's Wednesday's lab. For today's lab, we're going to have a sheep heart dissection. So we'll talk about that a little. I have the procedures already out there. I have more here if you need them. I'll put them out later. But for those of you who have that procedure with you, look at that last page. And let me open this up and let me look at it with you. You should follow the procedure. Everyone should have one, so you're following the procedures together as a group. Everyone's contributing, right? I kind of walk around, I look for slackers, like who people are just kind of looking along. We want everyone to participate and be active learners in this. No slackers. Well, anyways, look at the last page. It's like you got 4 ventricles. I figure the average group might have 4 people. Maybe you have 3. Maybe you have 5. I'm okay. But everyone has to do the presenting, right? And so it's like, you can say, oh, I want to do the first one, anterior aspect. And like, you could do it. I come around and I check you off. Be patient. It takes me a while to get around to everybody. I get everyone through it. And then basically, you make it down to the bottom there. I've checked off everything. You're done. And you're good to clean up. When you come back from break, I'll have everything set up. I'll have dissection trays. I'll have tools. It's like, you guys bring your gloves and goggles. Yay. All right. And I'll have the waste management set up over there. Remember, our our sheep hearts are fresh, so they might be a little bloody. If you want to rinse them off, let's keep all the bloody rinses to that sink. I don't want every sink to be a bloody mess. Okay. So when we come back from break, just go right into lab. Let's take about a 20-minute break.